Good afternoon, everyone. I would like to thank our speakers, and especially those that are discussing a very challenging and a very current topic, a subject that has profound implications on the way health professionals operate, and with very important repercussions in the health industry. Digital education and mentorship for health professionals may be one of the most complex, one of the most challenging topics today. I believe that the recent experience that health industry has had recently, that has posed challenges and some opportunities at the same time. It's a dilemma, in other words. Because this is something that can be addressed. It can be solved. Especially when it takes into account the recent experience with the pandemic. Before we start, let me just say that I had the chance to be the editor of a magazine and a doctor on digital media, Dr. Dora Taufman. She says that the health ecosystem is faced with the disruption of traditional practices, among other factors, and that is given by digital technologies, apps, mobile devices, artificial intelligence, telemedicine, blockchain. They're actually changing access to health services and the relationship between doctors and patients and the relations between patients and their own health that will impact even peripheral areas such as the insurance business. Eric Tofal, on the other hand, in one of his bestsellers about AI, states that the largest contribution of artificial intelligence in the health industry is not reducing mistakes or the workload, not even curing diseases such as cancer. Rather, it's the opportunity to restore connection between patients and doctors. In other words, the challenges of including these activities that require a new perspective from the educational point of view, the educational model, things that have to bring in digital education and mentorship. This may be yet another opportunity than a problem itself. In that sense, this panel will try to bring in the contribution of Dr. André Nazar, Jonathan Lorber, and Julio De Angeli, based on their own experience, the experience of their companies, and even based on their own reflections about these elements, some of the things I have just mentioned. So this is the basis of our discussion, and I hope that this panel can be very useful at this day and age, at this FIS 2021. Before we start, but let me just say, let me describe my own personal experience. I graduated 50 years ago. I'm a surgeon. I have experience in public health management in the past 40 years. I played both roles for a surgeon or for doctors in general. Mentorship is key. Practical activities, the cooperation with other professionals. This has become a system by the Flex's report back in 1911 in the United States. It established the medical education, introducing the scientific basis for medical education. And some names of surgery in the early 20th century. William Osner, he emphasized mentorship, saying that it's just impossible to learn without that experience, that knowledge from experience. In that sense, this panel can provide us with that perception, what goes on today, what we can expect in the future. Once again, I'd like to thank all of you, and I'll give the floor to Dr. André Nazar for his initial remarks. You have 10 minutes. When you're about done, you receive a signal saying that the time's up. We'll be as flexible as possible so that you can conclude your remarks. Thank you. Once again, André, you have the floor. Good afternoon, everyone. It's a pleasure to be here today. Thank you, Josier. Thank you, Rodrigo. We do have to promote conferences like this one. The sharing of experience is key, especially today. I think the pandemic ended up speeding things up. The disruption in education of medicine, this is something that we were already noticing even before the pandemic. We realized that we could no longer do the same things we had been doing for 20, 30 years. When I graduated 25 years ago, I learned medicine in a way that can no longer be taught today. The world is different. The students' profiles are different. Expectations, technology, everything has been changing at an astounding pace. You can no longer afford to remain in the traditional ways. Of course, there's value in the way we learned. Methodologies we used in the past can be replicated today, of course. However, the technology, the hybrid model is being discussed time and time again, and it will be the future of medical education. We already see that today, and it will be more true in years to come. So initially, it was a major problem. We had difficulties in adopting a virtual model. When you talk about regulation, we had already received that approval to provide some services or some courses remotely, at least partially, but not for medicine. We were 100% focused in the face-to-face model. We had to reinvent ourselves, and we had to do that quickly. We had to make a face-to-face course, 100% face-to-face, and we had to transform them into a remote model. Both government-owned universities or privately owned, in less than a week, we're able to go back. We had to adopt that hybrid model. The first decision was, let's do what we do face-to-face remotely. Let's adopt the same model, the same learning model, and let's transform that into the virtual world. We began to real-time classes, live streams, maintaining the same schedule, the same times. We innovated, of course. We already had a lot of technology in labs, in clinics, in different scenarios. We put all these technologies into the virtual world, and we kept on improving day by day. So what was the perception on the part of students? We have a medical schools in Salvador with 2,000 medical students, 16,000 in health-related courses. What's their take? 800 professors, instructors that were not used to that remote model. And we were faced with day-to-day problems, and we addressed them day by day too. Of course, we learned along the way. So when we sit down and review that entire experience, we had an entire learning model that is face-to-face, using technologies back then. And then we're faced with newer problems, psychological problems, mental health issues for both on the part of professor and students. So that's why we came up with a mentorship program. Because when we teach medicine, we're already using the model that is problem-based. It's not only that, but it's more comprehensive. But we had some tutoring sessions, small groups, 10 students would have the same tutor or the same instructor for the entire semester, and they had that weekly meeting with that instructor. So that relationship changed to a certain extent. When it was face-to-face, they would discuss the case, and that's it. The learning lesson or the skills, the medical skills. But not this time. When there was that virtual session, they addressed psychological issues as well. So that was a major improvement, the way we see it. And students liked this new model. Just this last semester, we had that tutoring session assisted by technology, 10 students in the same digital platform, opening up or turning on their cameras with instructor there. They were discussing the case, the learning process per se. So students adapted quickly. Professors had a much more difficulty to adapt. Students are naturally digital native. However, overall, the acceptance of both professors and students is wonderful. We had some satisfaction surveys at the NPS. So that survey is defined by that hybrid model, and the results are very positive. We're not going to discard it, regardless of all the regulations, especially for medical education. This is something you can't simply disregard from now on. There's something else that worked very well too, was research mentorship. We had a boost in the research increase. So a 100% increase in the number of scientific papers that were published. But that's it. We're not going back to old ways, period. We know we needed to change, and we had already been working in that direction. And many of these new practices will be used in the future. And there will be publications, just like the schools of medicine are now publishing their experiences. We haven't seen any robust paper showing the results of long-term effects of this mentorship hybrid model, but we believe it's very productive. Everyone is adapting, and we're working in this disruptive fashion, just like health and education require. We have to think outside the box. We have to do things differently. Everything changed, and there's no point in just closing our eyes to that.
Thank you, Andre. Thank you very much for your experience and for reporting it with us. I think you have really made very important points and taking really this opportunity of learning from a moment of crisis, really learning important things. I really liked this project that you've reported of introducing as early as possible mentorship. In this process of preparing research projects, this is something that we normally could not find in medical courses. Research has also taken second stage and got more attention just during graduate studies. But I think that students right from the beginning of medical school should be exposed to research topics so that they can have a clear understanding of what research means and what science can do and how it can help us, really making science something more accessible and at the same time really providing better understanding for practice. And with that, I would like to thank your participant, Jonathan Lorber, and he is going to now share his 10-minute presentation with us. Thank you very much. It's a pleasure to have you here with us.
Thank you very much. I'm Jonathan Lorber from Tel Aviv, CEO and co-founder at Edocate, a novel virtual patient simulation platform for healthcare professionals. So I'm happy to be here and share my perspective and experience about medical education and how the pandemic accelerated the adoption of online tools and how we can take and leverage it to see how we can make the best fit of novel educational tools to healthcare professionals. I'd like to speak about the changing landscape of healthcare. So we are seeing an increasing aging population today with chronic diseases, and chronic disease today accounts for 86% of healthcare spending. This comes together with a shift of responsibilities to primary care because there are not enough specialists out there to take care of so many chronic patients. The demonstrated shortage in healthcare professionals, especially the generalists, the PCPs, the general practitioners, the nurse practitioners, and physician assistants, is costing lots of lives in the US and also outside. And we see a high demand and a high job growth rate for these practices out there. Another thing that we have to see is a consolidation of healthcare systems, which drive a need to reduce the variation in care today and improve the compliance to guidelines. As the previous speaker said, 50% of the workforce today are digital natives. They have a very short attention span. They need immediate feedback. They need something interactive, and they're all used to work on mobile. And like always, healthcare professionals are bombarded with a lot of information and overflow, and the dynamic landscape of healthcare is changing. So let's think together that we need to change the healthcare education, and we cannot continue with the same system that worked until now. We're seeing a big dissonance that 80 to 90% of medicine today takes place in an outpatient setting, while 80% of medical education today still takes place in inpatient setting. So we understand that we have to make a big change and give a big focus on chronic care and long-term patient management. We also need to understand that there's a need to focus on how can we handle comorbidities. No one comes to his physician only with hypertension, hyperlipidemia, or diabetes. We have to look at the patient as a whole and treat all of his diseases. We also see that the guidelines are changing rapidly. This is also the national guidelines, the targets. We also see that new medications are coming out, and existing medications have new indications. So physicians today have to know quite a lot in order to stay up to date and take care of our parents in their best way. So as we say, we have to adopt and help healthcare professionals to adopt education in an innovative way. But that's not only a move to online education and take the existing system and move it to the online. It's not just the digital version of a textbook, as we say. We have to think out of the box, and we have to adopt innovation and find the right fit that fits healthcare professionals' tight schedule, their learning habits, and see how we can make it a good fit to the day-to-day life. The last thing that we have to adopt when we're approaching 2022 is how we can use data. We're speaking about publishments and about data, and we speak in medical education about return on education, where data-driven courses and data-driven decisions are made, also in business and also in healthcare, where we adopt a lot of technologies. So healthcare education providers needs to measure the impact of education, not just to show that it occurred, but also to show what was the impact, what was the value of it, what was the change in competency level, and how do we help healthcare providers to change behavior using innovative tools. So where should we go from here? I think first of all, we have to understand how adult learns today in the online world, in the 21st century. So in Edocate, we thought how we can take, what we can take from serious games, because one of the things that we understood that healthcare providers and also medical students are human beings like all of us, and they like to be engaged with things that comes from the world of serious games. And also we have to understand that we have to build something that fits their very, very busy lifestyle and schedule. They are fed up of sitting for 1 hour in front of a lecture, in front of a computer, reading articles, answering multiple choice questions, and they need something different, something engaging. We also always have to think what's the motivation for the learner, because if we'll distribute a great motivation tool, we'll finish up with the minimum amount of learners if we don't really investigate and understand what's the motivation factor. So we have to think if it's a residency program, if it's a medical school, if it's an organizational mandate, or is it a regulatory continuing medical education, continuing professional development, or even maintenance of certification, and build the right fit of the tools in order to engage healthcare professionals. We have to really think and move from active learning versus the passive learning. So you can use interactive tools, you can use simulation tools, and we have to use something that will catch the audience and make them make clinical decisions, and that we will be able later on to show what was the data, what was the decision made, and provide personalized feedback to them and immediate feedback, because learners today wants to know immediately if they are on the right path or not. And as I said before, we have to use data. Data is used a lot today everywhere, also in healthcare, and we have to measure the impact of medical education. So we're measuring outcome and the change on the competency level of the learners to show what was the value of education, how did we help them change their behavior, how did we change the competency level, and also to let the instructors monitor the practice gaps and see what's missing. How can we help them? Thank you very much, and happy to be here with you.
Thank you very much for your insights and for your input. Extremely useful and quite challenging as well, right? We are all facing constant challenges. And the COVID pandemic, as you very well pointed out, has increased the need to implement different things. And at the same time, organize and have systematic changes based on the reality of the group in terms of age range, level of knowledge, and the clinical reality of the different systems. So as you emphasized, it's not simply going from on-site or from paper into digital world. It's not simply transitioning data into the computer. Quite to the contrary, we have to change the paradigm. And among the aspects that you highlight, the first one is motivation. We really have to understand among the professionals, depending on their level of interaction with the system, as a learner, as a beginner in the medical school, or as a graduate student, or even someone within continuing education, what is the education that this person, the motivation that this person has? And this is something to be identified so that we can encourage the discussion. I believe this is essential for a transformation to become effective and can really add value to the system, which is also a point of emphasis that you mentioned with us. In addition, we should have active methodologies. Passive learning, considering all the amount of information that is available on a daily basis to us, is something that does not develop critical reasoning. It does not develop a clear understanding of what's going on. Sometimes the passive learning is also something that prevents us from learning rather than favoring our understanding and improvement. So these are the key components of your talk, in my opinion. And said that, I would like to carry on by inviting Julio De Angelis, who's going to share his experience. He is part of one of the largest organizations in education, in health education in Brazil, and I am sure he has a lot to contribute as well. Thank you very much, Julio, for being here with us. Thank you, Santini. Thank you very much for your kind introduction. It's great to be here with all of you. I would like to start by telling you a little bit about our understanding of the scenario that has been very well described by my two predecessors. When we're speaking about medical education or any kind of education, the most important thing is how, as an institution, an educational institution, how can I train the best? This is the key question, the most important question. What am I going to do to train and bring on board these professionals? So we talk a lot about technology, distance education, and all that, but we don't like to talk about that in our company. We talk about technology-mediated education. This is what we call it. It is education. Everything we do is that. And the blackboard, chalk, technology, right? That used to be the technology of the past, blackboard and chalk. So really making students go from point A to point B. Now, today, what should we do to train the best professionals? What do we do here in the company to understand that very clearly? And André showed everything, or shared with us everything they've been through, and the same has happened with us. We now offer mental health support to everyone in our company, all our staff, partners. It's been very hard on all of us. And of course, telemedicine and mental health go hand in hand now. So what we have done is to put an end to that myth that technology is a threat. It is not. If we can see the bright side, in terms of education, technology is no longer perceived as a threat to teachers. And maybe André might share whether it has been the same in his case. We thought it would take, 20 years to break with this barrier. And overnight, everyone realized what technology meant to education. When we wonder what to do to train the best professionals, we have to understand how the reality of any professionals will be once they graduate. We have to understand the marketplace. We have to understand the career path they are going to follow and bring that into our classes, into our education content. In healthcare at large, we have 16,000 medical students, and there are 18 medical schools that are part of the program. We also have continuing medical education, graduate studies. There are about 50,000 students which are covered by our products. But we started studying what physicians were doing, how was the marketplace, what kind of technologies they were using, what were the main barriers and difficulties of access. So an education organization that can have a smooth flow is the organization that's going to obtain better results. It is bringing together what's going on in the market and the classroom. This is the main secret to all of us who work in education. Technology should not be the main focus. So the first challenge is bring together the real world to the classroom. And secondly, and Jonathan pointed it quite well, what about engagement level? How do people prefer to study? And there are dozens of challenges that we all have to face to keep high motivation levels. It's not easy, we know. We use active methodology constantly. Feedback is constantly given. There are some teaching weeks, there are learning goals, students are assessed and get feedbacks. So these are cycles that are repeated, and educators at the same time get feedback. So this is the system we currently have in our medical curriculum. This is how we can understand, based on data, as Jonathan pointed out, how to obtain best practices from different organizations and share them. Of course, we have many schools as part of our organization, and as such is very good and easy to share best practices. And we can learn from the experience of different organizations. What happens in a hospital in, let's say, Porto Alegre, or another one in Teresina up northeast of Brazil, are completely different. So how can we really train the best professionals in a very comprehensive fashion? Last year, we acquired companies that worked in the pursuit of solutions to physicians that can be used throughout their careers. So this was way of connecting the market and what was going on with the students. And we really constantly dive into the characteristics of our medical students, because that's only by doing that that we can understand what else they need to bring on board more information to them and to serve as a feedback to my own system. Mentorship is absolutely essential for everything that we do in education. Mentorship is something that's going to be maintained throughout the whole career of professionals. I am not a physician. I am a business administrator, and I've been working with medical education for nearly 5 years now. And mentorship can be addressed differently. Let's say a simple app sending messages saying there is a new paper about the specific research topic interest. So technology really helps this process for it to be much more seamless and continuous throughout the whole medical career. Well, to wrap up and to try to anticipate the future, we have recently heard from Mark Zuckerberg the change of the company name and the concept of metadata. And this is a trend, but we don't know whether this is going to turn into reality or not. Coming from an organization such as Facebook, where there are over 10,000 people thinking about that, I am sure they have already run a number of studies. So I think that different teaching organizations have to consider those trends, and we have been doing that. We have some class technology with holograms. We haven't done yet because of the pandemic. Now we are going to resuming it. But so having someone in an auditorium sharing information wherever people are. And just to wrap up, classroom now is global. Our organizations are never going to succeed on our own. We need partners, especially in health education. And the pandemic has really confirmed that. The whole educational system, the health education, has to make partnerships with organizations throughout the world. And this is something that we have been developing, and that were my initial thoughts. Thank you very much. Back to you, Santini.
Thank you, Julio. Thank you for your remarks, how your company can contribute to this debate. I think you touched upon very important topics, but let me point out one aspect that seemed to be very important indeed. Looking at the job market, and the way you look at it has to be comprehensive in trying to understand the market's characteristics and the changes that a market will provide. Education as a whole can't be a repetitive process, something that will be just a mechanic reproduction of the marketplace. It has to have a dynamic point of view. And there should be some interaction between the educational project and the health system in which that educational project is included. So here comes my first question to all of you. Okay, based on this perspective, based on these changes, so what is your opinion about that relation between education per se, how professionals are formed, are educated today, vis-a-vis future challenges in the job market? I know it's a very complex issue, but I would like to each one of you to take at least one component of this, something that is on your radar, and something that has been considered by the organizations you work for. So what's that relationship between what you're doing today and the current job market and the future job market, considering these different scenarios? I don't know, maybe Jonathan, would you like to go first?
Yes, please. So I want to touch a few points that you've just mentioned. I guess the first thing that we have to remember is that the students, or the medical students of today, are the medical providers of tomorrow. And as the pandemic accelerated the migration to online, we'll have to remember that this generation will be used to adopting innovation, technology, not only now in medical schools, but also later on as they continue to provide healthcare. As saying that, I want to say that technology can also change the time to competency. If we're used to a model that the medical student has to be for X years in medical schools, if we're moving and migrating to a blended model that also includes online learning, and we can measure each one's competency level, not only now, but also when they graduate, maybe we can be more adept to the needs of the market, as you said now. So we can maybe have more physicians out there in the market in a shortened time. I think that when we look at physicians today, or even in medical school students, we have to enhance their confidence. That's the major thing. We have to enhance their confidence, and we have to teach them how to teach, because medicine is something that they're going to teach for all their lives. The dynamics in the market are going to change. Researchers are going to change. Guidelines will change. New medications will come in. Old medications will go out. So one of the skills that we all have to give to this young generation is how to learn, how to be efficient, how to enhance their confidence, and how we can reflect back to them. You know, self-reflection in education is something very important. So how can we reflect back to them at what position they are, where are their gaps, where are they going, and what are the needs of the market? The last thing I want to say that, you spoke about Zuckerberg, the previous speaker, etc. I think that when we speak about medical education, we have to remember the possibility to reuse of content. So if a great faculty from Rio de Janeiro created a great modality for learning, there's no reason that another faculty from a different place, a different country, a different city will be able to use the same content. And the previous speaker spoke about collaboration between medical schools, between medical associations, and even between hospitals. And the reuse of content in medical education is something that is vital in order to enhance the learning all around the globe and make sure that we are bringing the impact of innovative medical education to each student and to each learner. Thank you very much.
Thank you. André, would you like to comment on this relationship between schools in the market. Yes, just wonderful. Just great to be part of this conference because we all think alike. We're all faced with the same or similar problems anyway. What kind of doctors do we want to prepare or to train? Where are they? What resources do they have? You have doctors working in small villages and in a capital city with several hospitals, a lot of technology. That's the first thing you have to make a difference. I usually say conception is key. What's the conception behind that project? Who are we going to give that project to? And the second issue, which is even more complex in the way I see it, when you think about a professor / doctor, a doctor is not trained to be a professor. They are trained to be a doctor. They can resuscitate a patient. They have to deal with very serious cases. But his or her relationship with the learning process is not part of their own DNA, if I may. They have to reinvent themselves and learn, to teach this new generation. These generation does not look at the end result only. They go deep into how they learn. How are you going to train these doctors so that they can become medical professors of these new medical student? A medical student won't get frustrated. They're not used to frustration. And learning medicine requires being frustrated all the time. When you have the first terminal patient, for example. So with the methodology we have been using with several medical schools, Julio has been doing this too. We are replacing that methodology to show the young kid that how are you going to deal with, to have the right to make a mistake here so that you can do the right thing in front of a patient. So the first time I had to see a patient, I saw a terminal patient. You can provide a simulation that will look and feel real. I'm not talking about technology per se. Technology here is the way you teach. There's no point in investing millions in technology. You can purchase a robot. You can buy all the technology you want. If you do not provide students with the right learning tools, we won't get anywhere. There are simulation platforms that will cost a fortune, but that's not the solution. The solution is the model we adopt. And what model are we going to pick? These are major groups. These large groups have to join forces to come up with that vision of the future. Because medicine will become a commodity if we do not do the right thing. So that's the way I see the market going. Are you okay with that? Okay, let's move on then. Let me pose another question. This is a constant problem we have. The Century of Surgeons, that's the book I have in my hands. That's from the American College of Surgeons, published back in 2012. This book raises a relevant question the way I see it. From William Haggard. In 1913, that surgeon says, the number one danger of an occasional surgeon is not having special training. That's a surgeon speaking from 1913. It's just as current today as it was back then. Training. With that tutoring, with that presential tutoring, is fundamental. In surgery, of course, I'm a surgeon. That's my experience, of course. And the same thing applies to the learning process. But you raised another point, which is also correct. The notion of having that number of years of medical training is an arbitrary decision. A medical course may take 3 years, 5 years, 6, or an entire life. Actually, it is a lifelong learning process. Learning medicine is a constant and permanent process. You'll be learning all your life, including new knowledge, new technologies, new methodologies to have information access. This takes place in an ever-changing environment. This is an arbitrary decision. Every country will decide when a person can graduate to become a doctor. That does not mean that the person is capable of performing everything that is expected from a doctor. It's only obvious in medicine. So the question that was asked, what kind of doctor would you like to train? This is the $100 million question. That question has been asked for many years, and there's no definitive answer. That question will be answered differently depending on the situation, the time, both from the society point of view, as well as the knowledge currently available at that time. When you have a strong demand and there are many public health related problems related to water and sewage treatment or transmissible diseases or infections. So we would require in such an environment doctors that have more of an epidemiological background. On the other hand, you may need other types of doctors depending on the context. So the doctor we want is the doctor that is appropriate to their environment. That may change throughout his or her life. I'm just making these comments based on your comments because that concludes my part as a moderator. This is just an insight, a challenge so that we can reflect upon these things in the future. On behalf, so I'd like to give each and every one of you 3 minutes for your final remarks. Actually, it's just a reflection where we are, where we want to go. This structure, these models, I hope they can help us in the way we train doctors and health professionals. Things will be different, absolutely. But we should go back to traditional ways of teaching. Of course, we have to adapt to the times and to the characteristics in which we are inserted. And we have to train people that are passionate about medicine. I've been doing this for 20 years, and I'm passionate about what I do. Once you do that, this becomes a life purpose. I hope these kids can see that as their own true calling, a life purpose.
Jonathan, once again, your final remarks. Thank you very much for your participation. I hope you can have you at other meetings.
Thank you very much.